Thanks everyone for joining the webinar today. The topic today is platelet dose matters. So I'm going to be talking about some of the most recent clinical studies that were published that show that platelet dose in our PRP treatments can correlate with better clinical outcomes. We're going to do about 15 to 20 minutes of slides and then 15, 20 minutes question answer. So just a quick review of blood. Your blood has your liquid component, which is the plasma, and then you have the solid components, the red cells, white cells, and the platelets, which are the important cells in the blood. So what are platelets? Platelets are very critical for healing. They are the cells in our blood that are the first responders to an injury. They get activated in response to an injury. As most of you know, they aggregate and form a clot to stop bleeding, but more importantly, they secrete numerous growth factors, which are critical in healing. And what is PRP, or platelet-rich plasma? It's where we take a sample of a patient's blood and then concentrate the platelets out of that blood sample using a centrifuge. So the centrifuge process will separate the different cell layers based on weight. So the red cells, which are the heaviest cells, will go down to the bottom. And then that middle layer, that white layer, is the concentrated layer of platelets. And then the top layer, the yellow layer, is the plasma. So if we take the concentrated platelet layer plus some plasma, we have PRP, or platelet-rich plasma. And what do we use PRP for? We use it for treatment of chronic tendon injuries, so partial tendon tears or tendinopathy. PRP can help to jumpstart the tendon healing when the body has failed to do so. We also use PRP for joint osteoarthritis. PRP can be very effective for helping arthritic pain. It can improve the joint microenvironment, reduce inflammation. It actually slows the degenerative process, so it actually has a chondroprotective effect. It can protect the cartilage from further degeneration. Now, most of you know that not all PRP treatments are created equal. There are currently more than 64 different PRP centrifuge systems on the market, each producing a different type of PRP. This picture is an example of PRP samples produced from the same patient, but using different PRP devices. So you can see how different the PRP looks depending on which system was used. So what are the different variables in PRP? The red cell number can vary depending on which system you use. In that prior picture, you could see there are some PRP samples that were very bloody, had a lot of red cells. Those are outdated systems. We like to remove all the red cells from PRP. The white cell content can vary from PRP depending on the PRP formulation. So you have leukocyte-rich PRP, which is high white cells, and then leukocyte-poor PRP, which is low white cells. In general, we like leukocyte-poor PRP for treating joints. For tendons, it's a little more controversial. But the most important variable in our PRP is really the platelet dose, or the total number of platelets that we're delivering with our PRP treatments. Intuitively, you would think that higher platelet dose is going to give you a better clinical outcome because you're going to be able to deliver more growth factors from those platelets. But what is the optimal platelet dose? We don't have that, haven't had that information for a while. If you're treating someone with a medication such as an antibiotic, we know what the optimal dose is to get a clinical effect. But for treating our orthopedic injuries with PRP, it's really only in the last few years that we have enough data to really determine what the optimal platelet dose is for PRP treatment, specifically looking at treating knee osteoarthritis. Another term that you may encounter when talking about PRP or PRP systems is the platelet concentration, which is the factor increase over baseline. So, for example, a PRP system can concentrate the platelets 5 times over the baseline platelet concentration in blood. So that system, if you're getting at least 5 times baseline, that typically is going to give you a decent platelet dose. However, you have to be aware that platelet concentration doesn't always correlate with the actual platelet dose. For example, if someone has a low baseline starting platelet count in their blood, if you concentrate it 5 times over the baseline, it still may give you a lower dose PRP. The platelet dose may not be that high because your baseline was low to start with. or if you're concentrating the PRP 10 times baseline, if you're only getting a very small volume of PRP, again, the total platelet dose may not be sufficient or still low. So now I'm going to go over some of the studies looking at platelet dose specifically for knee osteoarthritis. This was a study published in February 2024 in the American Journal of Sports Medicine. It was a randomized controlled trial looking at 99 patients with early knee osteoarthritis treated with PRP and followed for 6 months. So the first group, Group A, received a PRP injection of 4 milliliters with an average platelet dose of 2.82 billion platelets. Group B had received double that amount, so they received 8 milliliters of PRP with an average platelet dose of 5.65 billion platelets. Both groups showed significant improvement compared to baseline, but results were significantly better in Group B compared to Group A, so the higher platelet dose group did better. At 6 months, patient satisfaction was 96% in Group B versus 68% in Group A. So conclusion is that higher dose PRP with greater than 5 billion platelets was better than the lower dose PRP group for early knee osteoarthritis. Here's another landmark study by Bill Berrigan. He's from University of California, San Francisco. It was published in March of 2025 in Arthroscopy. He did a systematic review looking at 29 different randomized controlled trials with 31 study arms that compared PRP to other injection therapies for knee osteoarthritis. And he was only including studies that included the platelet dose in their study. So there were 31 study arms that had 6-month follow-up. And of those 31 study arms, 28 of the 31 showed that PRP was had significantly improved outcomes compared to controls. And there were 3 negative studies that didn't show that PRP was significantly better than controls. There were 18 studies that had 12-month follow-up. 16 of the 18, again, showed that PRP was superior to controls. And there were 2 negative studies that didn't show that PRP worked. So he analyzed the platelet dose, looking at what was a platelet dose in the positive studies versus the platelet dose in the negative studies. And what he found was that in the positive studies for PRP, the platelet dose, mean platelet dose was 5.5 billion, whereas in the negative studies where PRP didn't work, the platelet dose was much lower, average 2.3 billion. So he concluded that improved clinical outcomes may be related to greater platelet dose. This is another study by Bill Berrigan, where he analyzed PRP for various musculoskeletal conditions, not only for knee arthritis, but also arthritis of the hip, shoulder, and CMC joint. He also looked at tendinopathies of the rotator cuff, patella tendon, Achilles tendon, gluteal tendon, a tennis elbow, as well as plantar fasciitis and carpal tunnel syndrome. And he was trying to see if there was any correlation between platelet dose to clinical outcomes. And what he found was that, again, for knee osteoarthritis, there appeared to be a potential dose response relationship between platelet dose and PRP effectiveness for knee arthritis, pinpointing an optimal threshold of 10 billion platelets for favorable outcome. For other conditions, looked like lower dose could suffice, but the optimal dose for other conditions was still unclear based on the data. There wasn't enough data to make a conclusion on optimal platelet dose for other orthopedic conditions. This was a study published in February 2021, a trial that included 150 patients with moderate knee osteoarthritis. They were randomized to receive either a PRP injection with 10 billion, with a platelet dose of 10 billion versus a hyaluronic acid injection. They found that both groups had significant improvement at 1 month, but the PRP outcomes were superior at 3 months, 6 months, and 12 months. Now, this author concluded that an absolute platelet count of 10 billion platelets was crucial in a PRP formulation to have a long, sustained conduit protective effect for up to 1 year in moderate knee osteoarthritis. Now, in my opinion, that conclusion was a little bit biased. I think the only thing you can really conclude from this study was that PRP with 10 billion platelets was better than hyaluronic acid, but because he didn't include another arm with comparing it to PRP with 5 billion platelets. So I think it's a stretch to say that you need 10 billion platelets in PRP. So I'd like to see that study where they compare PRP with 10 billion platelets or more to a lower dose PRP with 5 to 7 billion platelets. So that would be a good study. And then there are, again, multiple PRP systems on the market with variable ability to concentrate platelets. And this was looked into by a few different authors. Magellan analyzed 36 different PRP systems, and he found that 20 of the 36, or 56%, produced PRP with a dose of less than 5 billion platelets. So a lot of the PRP systems out there produce weaker PRP where you're not getting to that 5 billion platelet mark. Fadadu also analyzed 33 PRP systems in another study, and he found similar findings where a lot of the PRP systems were producing PRP that was weaker, not getting to that 5 billion threshold. So how do we really quantify how many platelets are in our PRP? The only way to really quantify the number of platelets is using a cell counter. So the cell counter will count the number of platelets on our whole blood at baseline and then calculate the number of platelets in our PRP samples. The cell counter can also quantify the number of red cells and white cells in the PRP. So let's say you have a patient who had a PRP injection and the clinic they went to didn't have a cell counter. How can we be sure that you may have had a high enough platelet dose? So a couple clues to suggest that you had a good enough platelet dose would be how much blood did they take from you? You really need at least 60 cc's of blood, 60 mLs of blood to reach that 5 to 10 billion platelet dose. Some of these systems are only using 15 to 20 cc's of blood. So even if those systems can capture all the platelets from that blood sample, because you have a lower number of platelets to begin with in that lower blood sample, the platelet dose is going to be much lower than the 5 billion mark. Also, if you're injecting 2 joints with PRP, you want to take double the amount of blood. So if you only draw 60 cc's of blood and then you split that between the 2 joints, you're underdosing each joint because you're only getting half the amount of platelets into each joint. And then I try to find out if from patients, what PRP system were they using? There are certain systems that we know can concentrate up, to 5 times baseline. So if they drew 60 cc's of blood and it was a PRP system such as MSite, usually you're going to get to that 5 to 10 billion mark platelet dose.
Just to give folks a reference, Dr. Evangelista, the average patient has about 200,000 platelets per microliter. So that's about a drop. By the way, your body makes about 10 million platelets per second, which is a mind-boggling number for me. But that aside, the average patient has about 200,000 platelets per microliter. So if you're pulling 60 milliliters of blood, you're pulling about 12 billion platelets from the patient. If you assume then that the system is going to lose some platelets in the processing, and some systems are better than others. We actually use a manual system. So I say we make our soup homemade. So our soup is homemade. It allows us to get better recovery of the platelets, but it also allows us to customize it in certain cases. And that's important if you're treating the spine or some other body parts. But if a physician, and this is very common in San Diego, I have colleagues in town who do PRP therapy. They don't do it very often. They'll buy an inexpensive centrifuge system. It'll come with a 10 milliliter syringe. 10 milliliters, you're only pulling 2 billion platelets. That's not enough to treat a large joint like a knee or a hip or a shoulder. So that's a clue as a patient. I think you should be advised because you're paying cash for this service. So you should get the best possible service you can get. So if you're not pulling the right volume of platelets to begin with, then you're not delivering that at the end. And you're not going to get the result based on these studies that Dr. Evangelista is showing you.
Thank you. So as Dr. Rogers alluded to, at our group here, we do platelet counts on all our PRP samples to verify the number of platelets. And typically with our 60 cc blood draw and processing, we're almost always getting between that 5 to 10 billion range in our PRP dose. But the nice thing about our system is we do manual processing, so we can customize that PRP. Let's say I know a patient has a lower platelet count to begin with, then I may draw more blood and process more blood to achieve a higher concentration of platelets, a higher platelet dose. Or if we want to shoot for that greater than 10 billion mark of platelet dose, then I'll do 90 or 120 cc's of blood drawn to make their PRP. Also, if we're treating the smaller joints to get that high dose in a small joint, because that volume is going to be a lot lower, the amount of PRP you can get into that joint, we can concentrate a higher dose of platelets in a smaller volume and deliver a good dose into these smaller joints. So in conclusion, based on the literature that I reviewed, the optimal platelet dose in PRP for treating knee osteoarthritis is in that 5 to 10 billion platelet range. Possibly 10 billion could be better. I'd like to see studies where they compare, 5 to 7 billion platelets versus over 10 billion to see, if that holds true. As I alluded to, many PRP systems produce weak PRP. Again, over in the studies by those two authors, over half the systems were producing PRP where the platelet dose was less than 5 billion. And that, again, you're not going to get as good of outcomes when treating an arthritic knee, at least based on the data. The only way to truly verify platelet dose is by using a cell counter. Most of the specialized groups that do regenerative medicine use a cell counter for their PRP. If you go to an orthopedic group where it's kind of one thing they do on the side, then usually they're not going to have a cell counter. And then the optimal platelet dose for other orthopedic conditions is still unclear. However, based on the data on knees, if we're treating a hip or shoulder, we're trying to, again, shoot for the larger joints. Again, we're usually trying to shoot for that 5 to 10 billion range in platelet dose. For smaller joints, such as the thumb CMC joint, we try to shoot for, because it's such a smaller joint, 1 to 2 billion platelets may suffice. For tendons, it's a little more variable. Some anecdotal evidence suggests that 2 to 3 billions for a tendon is a good dose. But I think tendon pathology is much more variable because of the size of the tendon and how bad the pathology is. So I think it's a little more variable treating tendons.
Also, a little more art to treating a tendon than a joint. A joint you simply inject into the joint capsule. There's fluid in each joint. Is contained within a capsule. Whereas when you treat a tendon, that's a little more technical, a little more artistic. That's where we use our ultrasound to make sure we're treating all the right areas. And that's a little harder to study. But one thing that we've done successfully is, I don't know, 7 years ago, we created a software program that made it easier for us to track how our patients were doing. And so every patient who's treated with PRP over the last 7 years, really, or 6 years, I guess, has complete surveys at 3 months, 6 months, 12 months. So we know how they're doing. And now we can correlate that with the dosage that we gave, the protocol that we use, so we can identify best practices. And that's a database that's now used by 300 doctors around the country, but it started here in our clinic. And that's helpful because there's so many different orthopedic conditions that are not well studied in the published literature. Knee osteoarthritis is very well studied. We have great data, but it really rapidly dwindles when you look at, say, a thumb joint or a rotator cuff tendon. So having that database, knowing how our patients are doing with different protocols is key to so we can just continually evolve and optimize our protocols. Now, Ed, we only got 10 minutes. We have some really great questions. Somebody jumped right into spine here. Herniated disc, is PRP, is there evidence that PRP can be helpful for disc, and what's our general approach? So the answer is yes. Ed has a more complicated answer.
Yes, we use PRP for discs. Again, we don't know the exact dose you want for a disc, but in general, I've heard, if you can get in that 5 to 10 billion platelet range into a disc, that would be ideal. Again, you need the ability to draw a lot of blood and concentrate it down to a small volume, because those discs don't hold a lot of PRP. And when we inject those discs, it's very painful. So it's key to really get high number of platelets in a small volume to treat the discs.
If you go to our YouTube channel, we have a number of videos specifically on the spine. We're not going to get into it here in this conversation to talk about something called platelet lysate, but for herniated disc, we would actually make a special customized type of PRP called platelet lysate that seems to show better benefit for the nerve pain that goes along with that herniated disc. So we may not actually inject into the herniated disc, we may just inject around the injured nerve. So there's some good videos on that you can watch. Somebody here asked, can you use somebody else's PRP? First of all, you don't want to, unless you have to. There have been some published human clinical trials showing that, at least in young patients, injecting tennis elbow, for example, using somebody else's platelets is just as effective as using your own. There are some obvious concerns about disease transmission, maybe immune rejection, things like this. So this is not standard of care, but there are products being developed that are not yet ready. They're not yet FDA approved, but that might be a case where a patient, for whatever reason, you can't get blood from them. The quality of their blood's not very good. Who knows what the uses will be, but just know that it has been studied, but it's not widely used at this point. I think Dr. Evangelista addressed the question, what if your baseline platelet count is low? And the answer is we check that ahead of time. So we can take more blood, basically, to collect more platelets. So
yeah, really sometimes,
yeah, go ahead.
Sometimes I like to, if a patient has access to their labs, I can see what their last lab, we can check your labs just like your primary care physician checks your blood count. It has the platelet number, your baseline platelets in that lab study. So if I have that information beforehand, I can usually, if you're over 200,000 platelets in your lab test, then usually we're going to get to that for sure 5 to 10 billion platelet mark. If it's lower than that, then sometimes I'll say, ahead of time, I'm going to draw more blood because I know I need a little more blood to get to that threshold.
Honestly, it's never been a problem. We take plenty of extra so that we have the dose that we need. I think the key point is just that most clinics, I would say easily 75 to 80% of clinics that are not specialists in regenerative medicine, as our clinic is, are not dosing adequately, and for the reasons that were already stated. Somebody here asked, how much blood does it take to establish high PRP? I think you answered that question. We take on average 68 milliliters for a large joint, maybe less for a smaller joint. Can it be used to treat a tear of the labrum in the hip? Dr. Evangelista, you and I have both treated torn labrums, including people that are near and dear to us that we know that we've treated. I think you'd agree that the results are generally good. I think this actually, the more important question is, what is the complete diagnosis? So labral tears are exceedingly common for those of us over 50, 55, 60 and older. These kinds of tears are common. They may not be the source of pain. This is where it's important to see a licensed physician who is board certified in an orthopedic specialty such as physical medicine and rehab or orthopedic surgery or sports medicine, so that an accurate diagnosis can be made, because it doesn't do you any good to have an amazing PRP injection if the diagnosis is inaccurate. So that accurate diagnosis has to happen first. But in general, yes, we have treated many patients with labral tears. The result, I can't quote you an exact success rate, but when you're in the office, we dig into our data biologics database and we can tell you if you're 52 years old and you have a labral tear, what's the chance of success? So we're getting very, very good data on that.
Yep.
Here's someone asking about a doctor in Michigan. You know more about Michigan than
I am from Michigan. I grew up in Michigan, but I have not heard of Bronson Hospital. I know that there is a regenerative group in the Troy, Rochester Hills area. Tom Nabity and John Santa Ana. I think it's called the Center for Regenerative Medicine in Michigan. That's the only place that I know that does good work with regenerative medicine and PRP.
And we know that those doctors use the same database that I referred to earlier, the Data Biologics database, and we know that their outcomes are very good. So, it's one thing to get a recommendation to a physician that's a friend of yours. It's another thing to actually know how good their outcomes are. We actually have data on their outcomes. So we know they, like our clinic, are one of the top 8 clinics in the country. So a good recommendation there. The question we've been getting for 16 years, Dr. Evangelista, when will insurance pay for PRP?
Oh,
Heartbreaking.
yeah. I
They
mean, if you look
absolutely
at the
should.
data, yeah, it's
I used to
mind-boggling.
think I used to think that we didn't have enough clinical studies for insurance companies to adopt PRP, but that's not true anymore. We have thousands upon thousands of clinical trials, including our real world database. So we're not lacking in data. I think the issue is what you highlighted earlier, is that it's not standardized. You go from clinic A to clinic B and it's a different protocol, a different platelet dose, a different doctor, a different technique of a delivery. And it's difficult, I guess, for insurance companies to pay for something when they don't know what they're getting exactly. So we try to set the bar. Hopefully, uh, we get enough doctors around the country to come up to that bar. And at that point, I think insurance company will realize that it is cost effective. It's clearly superior to many other things that we do that are reimbursed by insurance, such as the hyaluronic gel injections, the steroids. It's not even a question anymore whether or not PRP is superior to steroid injections or hyaluronic acid. That's very well documented in scientific literature. So much so that I think it's unethical. I'll just go on the record. I think it's unethical to offer these inferior services when PRP is clearly superior. Unless it's just cost prohibited by the patient, I guess, or for some reason they can't have their own blood as a treatment, which is rare. We do avoid treating patients who have active cancer. So if a patient has leukemia, lymphoma, I think there's more questions than answers regarding whether or not it's safe to use their own blood. But just an abundance of caution, we don't generally offer PRP to those patients. But pretty much everybody else is a candidate. Even patients on blood thinners, we can temporarily take them off their blood thinners, and it's not a problem. What other questions do you see?
Do you do you do several joints during the same visit, i.e., both knees and disc? We do. Yeah, we can definitely do a lot of times multiple joints in one visit. I try to limit it to 3 to 4 areas at once, but if it's more cost effective and convenience wise for the patient, then yeah, we could do multiple areas at once. We just have to draw enough blood. If we're treating multiple areas, for bilateral knees, we're drawing double the amount of blood for each joint. And then if we add in a shoulder and so forth, we just draw more blood.
Yeah, there's really no limit. We're not taking large volumes like you would when you're donating blood. So these are low volumes. And it's just a matter of, how many joints you want injected in the same day. We have a lot of patients who fly from out of state or, I mean, sometimes out of the country that come. I don't know how they find us. They do. And then they have, 4 body parts that need treatment. That's rare, but it does happen. But if you're in the neighborhood, then we can space out your treatment if you have multiple body parts too. Someone has a question. It's not related to what we're talking about, but they're just asking, does the FDA still disallow stem cell therapy from a placenta? There are no FDA-approved studies for stem cell therapy in orthopedics. That is still true today. We've been saying that for a decade. It's still true. However, we do now have the first ever FDA-approved stem cell therapy, but it's for the treatment of something called graft versus host disease. So hopefully something none of you are dealing with. It's usually a child will get a kidney transplant or a heart or a liver or something, and they will have an immune reaction to the transplant. Stem cells have now been approved for that condition, but nothing in the orthopedic world at this point. Actually, someone did ask this question. Are some insurance companies approving PRP? So, we said they're not, but For a while, TRICARE was, they
Yeah.
stopped doing that. I don't know why. There are several self-insured companies, so you may work for an employer who has a fund that they use to pay for their employees' healthcare. Many of those companies they've realized the cost savings, certainly when compared to surgery. So they will authorize PRP use, but Medicare does not, but Blue Shield, Blue Cross, Athena, all these have not yet adopted it. Oh, some workers' comp will pay for
Yeah.
PRP
Yeah.
as
Yeah.
well.
How do you determine if knee arthritis is a candidate for PRP?
Yep.
Most of the studies are definitely positive if it's mild to moderate knee arthritis, good candidate for PRP. In the more severe cases, the success rate goes down, but I definitely have several, multiple patients who will still do well with PRP, even if they have, in that moderate to severe arthritis range.
Agreed. It's a case by case decision. We look at the patient, we see if they're a good candidate or not. I saw a patient today with very severe arthritis, but I think will benefit from the treatment. In general, obviously, the less severe the condition, the more likely the results will be good and long lasting. But it varies. It varies by person. We got a few more questions. We're over time, but I hate leaving questions unanswered. Can we just bang out a couple of these?
Yeah.
Um, when do you repeat it? There are many clinics that will automatically do 3 injections. We think that's misguided. The scientific evidence is not there to suggest that that's helpful. I think a lot of these clinics have decided to do 3 injections because perhaps their dose is low and they think that doing multiple doses is a good idea. The data has shown that if you do 3 very poor, say 2 billion platelets, 3 very poor PRP injections is not superior to 1 well-done injection. So we prefer to just do 1 well-done injection. If our patients has knee arthritis, for example, and 2, 3 years later they come back, their knee pain is back, we will repeat the treatment, but typically not routinely. And I would say at this point, probably 10 to 15% of our patients will get repeat treatment at some point in time.
Yeah, I have some patients who want to be more proactive because the PRP can have a chondroprotective effect. And if they already have moderate to severe arthritis, they have a good result, then sometimes, once a year or 2 years to repeat it definitely can't hurt and could potentially help.
Yeah.
And someone asked about spinal stenosis.
Yep.
Yeah, that's more of a structural. If the canal is just too tight, PRP may not be effective for that. It's that, and if the symptoms are mostly leg pain from the stenosis because the canal is too tight, then PRP will likely not be very successful for something like that. We can do like platelet lysate, which can help the symptoms temporarily. That would be equivalent to doing a steroid injection, but using growth factors. But if the underlying problem is the canal is too tight due to the stenosis, then that's
As you know, a lot of patients do have stenosis on their MRI, but that's just part of the story. If they primarily have low back pain, the pain may be due to the arthritis in the back, not the actual stenosis. And we've had good results using platelet lysate or PRP for arthritis in the low back. So again, we can't make broad sweeping generalities. I would say I agree with Dr. Evangelista. If the MRI shows very severe stenosis of the nerves are severely compressed, I would say the odds of PRP being helpful are pretty low, pretty limited. But again, we just look at each patient, case by case. There's always a question here about cost. Price range, with discounts could be as low as 1,500. With a complicated case where you're doing multiple body parts, it could be as high as, I don't know, 3,800 or something like that. It ranges. Somebody asked about care credit. I think we do accept care credit. We do payment plans with patients where maybe a hardship, and we really just want to get folks treated. So we do whatever we can to make it affordable and easy for you. And we have folks in our office who can help you with that. There was one more question I wanted to answer. Somebody asked, does it actually heal the injury? And in the case of tendons and ligaments, I think the answer is yes. I think we are healing the tissue. I think if we catch it early enough, if the tear is not too big, I think if we do a high dose of platelets and get it in there and do the right rehab, I've seen many, many cases where it's one and done. It's one treatment, and then the tendon heals, and then they're good, and they never need any repeat treatment. So I would say that's true. In the case of osteoarthritis, in most cases, it's a progressive disease, and repeat treatment will probably be necessary at some point, years down the future. Age does not matter. Someone asked about age. Age doesn't matter. It's really about your health. And so if you're a healthy person with the right type of condition, these treatments can be helpful. All right, we zipped through. We went 5 minutes over. Thank you, everybody, for your great questions. If we didn't get to it, I apologize. Feel free to call us, email us, text us, visit us. We have a YouTube channel where there are many videos on there where you can hear more about this. But we just wanted everyone to realize that dose does matter. And thank you, Dr. Evangelista, for a great summary.
All right. Thank you, everyone.
Bye.